Hello everyone, welcome to today's episode of the Differential podcast. Today I'm going to be discussing transfusion reactions with you. And it's really an important topic, not because of management questions. These are more straightforward. You will always discontinue the transfusion and manage the patient with hydration or antipyretic if we are talking about a febrile reaction. However, it's very important to diagnose these different transfusion reactions and be able to differentiate them based on the given history and physical examination and laboratory values. So I have an approach where you have to look at the three different variables, and these are going to be sufficient for you to understand and diagnose which condition is ongoing. So basically, when we say a transfusion reaction, this means someone's received a transfusion, usually backed red blood cells for anemia, and then developed some form of illness. Now, what I want you to know and look at whenever you have one of these questions is to see if this individual is having an acute or a chronic process. So first the timing, then if there is hemolysis. And hemolysis is not only labs. The question could sometimes not include labs. So you need to look at physical examination. Is the patient jaundiced? Do they have flank or back pain, which could happen with hemolysis? That's massive. And also if they have, what else? Laboratory values that are suggestive. So maybe hemoglobin, they show you the hemoglobin before and after, and it might have decreased or stayed the same despite the transfusion being given. Maybe an elevated LDH, low haptoglobin. All of these findings are going to be important for you to recognize, and obviously an increased reticulocyte count. These will tell you that this individual is having hemolysis. So timing, acute or chronic, then the presence of hemolysis, and lastly, examination of the heart and lungs. And this is really important when it will come to differentiating TACO and TRALI, and we will go to that when needed. So let's say that someone's have a hemoglobin of 7.5. They have ischemic heart disease, so the cutoff for transfusion is less than 9, and they were just given a blood transfusion with backed red blood cells, and 15 minutes after receiving it, they started to have hypotension. So they are hypotensive, less responsive, they are tachycardiac, and their temperature is normal. And the question tells you that the individual is itching his chest, and there is erythema developing that's raised on his arms, on his chest, and he is having shortness of breath as well. What do you think the diagnosis is going to be here? So timing, this is acute. Hemolysis, I don't see any signs or labs suggestive of hemolysis in my question. And then, is there chest exam abnormalities? Well, let's say that they mentioned on auscultation there is bilateral wheezing. So what does this patient have? Since there is no hemolysis, it's not acute hemolytic transfusion reaction, and it's not delayed hemolytic transfusion reaction. Since there is no fever, you completely rule out febrile non-hemolytic transfusion reaction. So you are left with TACO, TRALI, and anaphylactic reaction. In TACO and TRALI, so TACO, which is transfusion associated circulatory overload, or transfusion. It's basically someone given a transfusion and their heart can't handle it. Usually it happens in individuals with previous heart failure or with end-stage renal disease, where fluids, it's a kind of a messy thing. So why this is not TACO? There is bilateral wheezing. Sometimes you could have bilateral wheezing with heart failure, but where are the crackles? Where is the GVB? Where is the S3? Where there is the displaced maximal heart impulse? I'm not telling you that the question should give you all of these. Where is the peripheral edema? However, if all I have is bilateral wheezing, this is not sufficient for me to say this is TACO. All right? How about TRALI? Crackles. It will never be wheezing. And even heart failure, usually bilateral respiratory crackles, it could be combined with wheezing. So from this picture, it looks like an anaphylactic reaction, and also neither TACO nor TRALI would explain the itchiness and the developing wheals or rashes, which is urticaria. So this is an anaphylactic reaction, and if they ask you about the mechanism, it's going to be mast cell degranulation. And mast cell degranulation happens when IgE binds an antigen and then binds mast cells. Now, what's the antigen here? Usually, and that's one question they could ask you about, like which individuals are predisposed to anaphylaxis after receiving a blood product. It's individuals with selective IgA deficiency. Why? They don't have IgA in their body. So when their thymus was developing these T cells, it didn't negatively select, which means it didn't delete the T cells and T cell receptors and that were recognizing IgA, because he has IgA deficiency. So this protein is foreign for his body. So once you give it and he has these antibodies against it, the IgE of his body will bind with the IgA from the donor and then bind to mast cells, causing this degranulation and anaphylactic reaction. So people with selective IgA deficiency are at higher risk for anaphylactic reactions after a transfusion. All right. So obviously you need to discontinue. If someone is only having the rash, it's antihistamine. If someone is also having respiratory symptoms and laryngeal edema, just the symptoms even, and the wheezing, then they need epinephrine. That's the management of anaphylaxis regardless of the cause. Now, let's say that an individual received his transfusion, 15, 20 minutes, 1 hour, whatever it is. This is all acute. He is febrile and he is jaundiced more than he was before, or maybe he wasn't before. So he has jaundice now. And he has flank pain and dark colored urine that you can see on the catheter. And he's a bed-bound patient, let's say. That's why he has a catheter on. What else? Chest exam is clear. So what does he have? First, it's acute. There is signs of hemolysis. I have the jaundice. Maybe they will mention the labs, which I keep on repeating. Jaundice is sufficient for me. Newly developing, obviously. And also, chest is clear. So chest is clear. This tells me it's not TACO, it's not Raleigh. The patient is maybe hypotensive as well. So hypotensive and febrile. Is it an anaphylactic reaction? So hypotension alone doesn't diagnose anaphylaxis. There is anaphylaxis criteria. You could look them up. You need 2 out of maybe 4 or 5. There are multiples. It could include abdominal pain. Sometimes the presentation could be abdominal pain and hypotension. Okay, he has flank pain. But I mean, there's also hemolysis. Anaphylaxis will not explain the hemolysis that's clinically significant to cause jaundice. So it's acute hemolytic. You can see where I'm going. Like, look at the name, acute hemolytic transfusion reaction. Exactly. However, the patient is febrile. Yes, patients could be febrile with acute hemolytic transfusion reaction. That's why you need to pay more attention. So let's say that the same individual received the transfusion. He is febrile now. However, he is not jaundiced. If you look at the repeat CBC, there is improvement in hemoglobin, and LDH is normal, haptoglobin is normal, and red count is normal, or as before, there is no change in it. And the chest is clear. So now it's isolated fever, chills, rigors, whatever it is. This is going to be febrile non-hemolytic transfusion reaction. There is a reason we add non-hemolytic, because acute hemolytic transfusion reaction can cause fever as well. So you see, with the 3 criteria approach, you can really differentiate them easily. All right, so we have talked about anaphylaxis, acute hemolytic, febrile non-hemolytic. Now let's say that someone received their transfusion and 2 weeks later they come. They have some splenomegaly, some abdominal fullness. It's a bit irritating them. And you repeat the hemoglobin and you find that it came back to what it was before he received the transfusion. However, the patient is not jaundiced, and that's it. It could be just like that, and his chest is clear. So this is a chronic process, or not acute, let's label it. So that's the timing. Is there hemolysis? Definitely there is. You have some splenomegaly. Even without it, the hemoglobin came back to normal. So unless there is an active loss, obviously. However, in this case, let's say LDH is a bit elevated, there's splenomegaly. So this patient has lost blood due to hemolysis. So there is a chronic process after transfusion, obviously, with hemolysis, and the chest is clear. Now, this is a hemolytic reaction. However, this is what we call delayed hemolytic reaction. And this happens due to antibodies against minor antigens of the donor RBCs, and not the major antigens, which are the ABO. The ABO will cause acute hemolytic transfusion reaction. However, the minor ones like the KIL, the RH, and the D antigen, these usually cause delayed hemolytic transfusion reaction that doesn't present acutely. Now, finally, with the big bosses and the scary ones, TACO and TRALI. So, just before moving to them, to confirm the mechanisms with you. So, febrile non-hemolytic transfusion reaction, again, febrile non-hemolytic. This happens because of the cytokines in the backed red blood cell transfusion you are giving. So there is cytokines from the donor. Once they arrive into the host system, they will activate the inflammatory system. They will affect the hypothalamus and raise the temperature. For acute hemolytic, it's antibodies in our own body against ABO antigens. So that's why we do the cross-match to avoid this disastrous mistake. Delayed, it's antibodies, but again, they are not against the ABO. They are against minor antigens. And for anaphylaxis, it's because of preformed IgE targeted against antigens in the blood product. Again, there is an association where it could be IgA antigens, and the patient is a selective IgA deficiency patient. Now, TACO and TRALI, someone receives a transfusion, both of them will be acute. So they will have acute respiratory manifestations, shortness of breath, cough, bilateral crackles. These are shared features. So it's acute, there is no hemolysis, they will never be jaundiced. You will never find findings on labs that are suggestive of hemolysis. So it's acute, non-hemolytic, and it's majorly respiratory symptoms. Now it comes to you to differentiate if this is because of fluid overload and heart failure, technically, or because of lung injury, which is TRALI. It's transfusion-related acute lung injury, while TACO is transfusion-associated circulatory overload. So it's like cardiogenic versus non-cardiogenic pulmonary edema. How do I tell them apart? The cardiogenic, which is TACO, I'm going to have findings other than the lung congestion that suggest heart failure. Elevated GVB, displaced maximal impulse, S3 heart sound, peripheral beating edema. So elevated BMB. All of these findings will tell me this is TACO. While with TRALI, it's only bilateral crackles. Obviously, again, both of them will be respiratory distressed. They might be desaturating, tachycardic because of the stress. These are not things that will let you know. Both of them will have bilateral crackles. And they could give you the x-ray. With TACO, you will see a dilated heart, big heart, pulmonary congestion, while with TRALI, it's an ARDS picture. You are going to see washout, white lung, a lot of infiltrates everywhere. So that's how you tell them apart. Again, acute, non-hemolytic, and then you look at the chest. If it's only bilateral crackles and you don't have physical examination signs or heart auscultation signs suggestive of fluid overload, then that's only TRALI. If there is, then it's TACO. And management-wise, for TRALI, it's supportive always in all of these conditions. You discontinue the transfusions. With TRALI, it's mechanical ventilation. It's basically ARDS, so it's respiratory management. While with TACO, it's diuresis. They have fluid overload. You give them furosemide or Lasix to clear off the extra fluid that they have in their system. Back to the previous conditions, febrile non-hemolytic. Management would be antipyretics, not given prior to the transfusion in a prophylactic manner. That doesn't work. They must be given after it happens. How could I prevent it? There is a process called leukoreduction, where we reduce the amount of WBCs present within the blood product, which reduces the cytokines and reduces the risk of febrile non-hemolytic transfusion reaction. That's it. I hope that it's helpful. So you have 6 different conditions: anaphylactic reaction, acute hemolytic, delayed hemolytic, TACO, TRALI, and febrile non-hemolytic, with keeping an eye on the timing, the presence of hemolysis, and the cardiorespiratory examination. You will be able to differentiate them very easily every single time. Thank you for listening for this episode. See you in the next one. Bye-bye.